We're rolling. Thanks, Gene.
Awesome. Well, welcome everybody. I think I know how to I got way too many mice going on and stuff. I got lots of monitors going today. So, welcome. Thanks everybody for doing the pre-training, everything else we did. We're gonna jump right in because it sort of goes with some of the things you've already learned about. So, you watched a great video about the US healthcare system. We're gonna talk about it in a little bit more depth. I'm going to give you another glossary that I'll send out a little later today to add on the ones. We're going to talk about why we're doing it. We're going to do an exercise and you get homework. I mean, everything you want out of a presentation. No. Okay. So, outpatients, clinics, and care in the U.S. Yeah, that didn't work. Let's see. I got to figure out which of my buttons is going to advance this slide. Give me 1 second here. There we go. Okay, these look like huge amounts of words. You don't have to memorize all of this, but I wanted to make it for reference. And because one of the reasons we're recording this is so that we can use it to, once you guys tell us how it worked, what helped, etc., that we can use this for additional training programs. So we say ambulatory all the time. So, like if you work at an EHR, a lot of times we say acute and ambulatory. In real world, like if you're a doctor, I never say the word ambulatory. The word ambulatory means, like in hospital sense, is that someone can walk. They're ambulating means they're walking. So ambulatory means a walking clinic, and not. So we tend to call it outpatients. So I'm using both those terms. They're completely interchangeable. Outpatient equals ambulatory. Acute is what we often call, what again in the outside world we would call inpatient. So if you're in a hospital and you're admitted, you're an inpatient, right? If you're not admitted to a hospital and you're getting care on the outside the hospital, you're outpatient. Those tend to be the terms that we would use more as clinical people. I think even as layman people, but in the EHR world, a lot of times we use ambulatory and acute. So I want you just to understand that those are interchangeable. Now, I think everybody gets what happens when you go in the hospital. Now, we could be really technical and we could say that when you're in the hospital, sometimes you're on a kind of admission called a 23-hour stay. So you're not technically, according to Medicare terms, overnight. And it's billed differently, but none of that matters for what we're talking about, right? We just want to talk about TouchWorks because remember, the whole point of this exercise is to relate all of this to doing support, R&D, services, at TouchWorks and learning about our industry, our clients, our workflows. So we are an ambulatory or outpatient EHR. That means that the way our screens are configured, the things we support, we don't have features that might be used in an inpatient setting because we are not used in an inpatient setting. A great example of that would be, we don't have interfaces with IV pumps. Most of our clients in the outpatient, although we have, and we're going to talk about this, centers that might do an infusion where you come in just for the day, get a medicine, and you leave because that's becoming more and more common. We don't have a feature like that because when this product was designed, that was like unheard of, right? It's very uncommon, right? Today is becoming more and more common. So there's just things are different. A big difference is like when you're seeing a physician, and hopefully everybody's been to the doctor, you're usually put in a room where you meet the doctor, so the exam room, right? So we talked about exam rooms. We might have things that tell us room numbers. If you're doing inpatient medicine, it's the bed, right? There's 2 beds sometimes in a room, depending on the unit you're in. So it's all about beds when you talk about a hospital or inpatient system. So the vocabulary is different, right? So we're going to talk about outpatient. And there's some examples here is that, just having your blood drawn, that's an outpatient encounter. So it doesn't mean that you're just always in the doctor's office, although that's what we think a lot about, is there's all sorts of places. Like if you have outpatient surgery, that's still outpatient or ambulatory, right? It means you're not going to stay overnight. So where are all the places that we give ambulatory or outpatient care? Well, here's a random sampling. It's a lot more than you think. And that matters when we talk about the workflow and talk about supporting our clients. There are a lot of people. So if you're in assisted living, so assisted living in the US means that you're in a facility. That facility may also have a nursing home. It could be totally independent, but you're in assisted living. There's people to assist you, but that's equivalent of being in your own home for how medical care is delivered, meaning we bill the same way we would bill if you came to the office. So if you live in assisted living, there may be a doctor who comes to the assisted living and may see you there, but we bill it and document it just like you're in the office. Vice versa, you could live in assisted living and still go to your doctor's office and receive care. Matter of fact, you probably have both. So you start reading all this giant list, and guess what? The list goes on. So outpatient's pretty complex when you start thinking about the fact that, when most of us think about where we get care for outpatient or ambulatory medicine, we think of the doctor's office. But some of you may have kids who do sports, and you may know that you can get seen by a doctor in the athletic training room of your school. You play football, basketball, soccer, you get hurt, a doctor may have an appointment with you in the athletic training. Those visits still have to be recorded, just like the ones that happened in the office. We also see you on the side of the field. We see you in urgent care centers. We do all sorts of therapy that are outpatient. So you start to see that it's a lot more than just being in the doctor's office. A lot of you even may know through your experience, like physical therapy is on this slide. We have several clients who have physical therapists, right? A lot of ortho groups will have their own physical therapy, but occupational health has their own physical therapist. So again, we encounter almost all of these services in some way. Okay, so if you've been around us very long, and if you're not, you'll soon learn, you will hear the word provider all the time. Is somebody a provider? Are they a provider? Are they a provider? Okay, in real medical world, we don't ever really say the word provider. It's becoming more common because of APPs, which we're going to talk about, but really, we need to be more precise about the kind of provider. And the reason it matters, this isn't like a hierarchy thing. Well, I have to know, are they a real doctor or a nurse practitioner? It's not that at all. It's that it could influence how they're credentialed and how their workflow is. For example, a physician's assistant in most states cannot practice independently. Nurse practitioners can practice independently in some states, not in other states. Even when a nurse practitioner is practicing, some insurances they can bill under their own name, some insurances they have to do what's called incident to billing. Again, this isn't about knowing everything about the healthcare system, but the more you learn these terms and we can speak these terms, it does a lot of things for us in our case communication and our understanding of workflows. That's why this is so important. This isn't a name every role in a healthcare setting, but we're going to talk about the ones that are common that we're going to see in cases, that we're going to be working through things, and that we need to understand. So first of all, when we say providers and we talk about TouchWorks, the first thing that comes to my mind is always how someone is configured, right? You can be configured as a provider, a user provider, or a user. That's the highest level designation in TouchWorks when you're setting up an entity. So if I'm going to make a user ID for Scott Billings, for Rob Sloan, for Gene Armstrong, the first thing I have to decide is, are they a user provider, or a provider? So that's one thing. What you'll notice as we study vocabulary and we talk about different aspects of workflows in medicine, you'll notice the same word gets used a lot, but it sometimes have a different meaning, right? So in a case, if someone says they're a provider, I have to first be able to think, okay, TouchWorks terms. Do you mean they're configured as a user provider? Do you mean they're configured as a provider only? As a provider only, you're probably not getting the call unless they're talking about referral providers or something else, right? Or are we talking about their credentials? So physicians have two kinds of credentials, MD and DO. They're equivalent in terms of you go to a different school. One is allopathic, one is osteopathic, but they can all do the same stuff. Osteopathic has more hands-on manipulation and musculoskeletal, and their training. Allopathic doesn't. But under the law, they're considered equivalent. They're all doctors. Okay. And so APP is a newer term. You may have heard a term in the past called mid-level. That term is no longer in vogue. We should not use it. It's been replaced by the term APP. It stands for Advanced Practice Providers. The normal advanced practice providers are usually NPs, which are nurse practitioners, or PAs, which are physician assistants. And so MD, DO, PA, MP, those are people's credentials. You'll see a name written like Gene Armstrong, comma, MD, right? Betty Jones, comma, NP. Rob Sloan, comma, PA. Scott Billings, comma, DO. Jeff Wilson, comma, NP. You get the idea. A nurse practitioner in the U.S. is a registered nurse, so you have to be a nurse first, and then you can go through additional training to have practice equivalency, not 100%, but near what a doctor is credentialed to do. There's really not much they can't do, but there's still a lot of things they can't bill for. And that varies by state. So that's a nurse practitioner, and then a physician assistant goes to a training program called physician assistant. It's a master level program, so you finish college and then you go. But notice they're all doing similar stuff, right? They're diagnosing, treating, caring for, right? And then we have the term medical assistant. Now, in terms of credentials, you could see MA, you could say CMA. C stands for certified. So one of the big differences between inpatient and outpatient, and I'm just going to jump forward for a second. Even though we don't do inpatient, I sort of want to give you some terms that are really common. So when we say nurse, that's a really non-specific term. Matter of fact, I all the time will say nurse and then I will correct myself because it rolls off my tongue, and then I correct it with the term I'd rather have used. I try to do it ahead of time, but it's really ingrained. We use the word nurse way too much because nurse is really an abbreviation for a credentialed person, like a registered nurse, an RN. An RN has gone through more training than a medical assistant or an MA. They've gone through a nursing program, they've passed a license, like, so that is, and you will see them giving care in hospitals because they're credentialed to do more things than the comparison, which is the medical assistant. Medical assistants can just be called medical assistants. They don't have to go through a formal program. Most will go through a formal program and most will be certified, but they don't have to be. A medical assistant is also a generic term for the person assisting whoever is providing the medical care. In most states, they're allowed to take vitals, draw blood, give shots. But it varies by state. Most you can do that. Medical assistants both work at the front desk, so they get trained on sort of all aspects of the outpatient medical world. So a lot of MAs actually work at the front desk of medical clinics, doing scheduling, billing, etc., and then a lot work in called the back office. When we talk about workflows at TouchWorks, what I try to talk about is when I'm talking about what you might call a nurse, I call it back office. So in the back office, that way I'm not putting any credentials in it. I'm not saying who's doing the work. I'm asking the question. Okay, in the back office, who is taking the vitals? Janet. Okay, who is Janet? Is she a medical assistant? Is she an RN? Is she an LPN? LPN is another kind of nurse. It's called a licensed practical nurse. They have a little less training than an RN. Again, you will see RNs and LPNs in outpatient clinics, but it's 10 to 1. You're going to see maybe 50 to 1. You're going to see MAs more than you're going to see RNs. Again, why does that matter for us? It matters for us because it means they might not have the same configured in the EHR. So understanding the difference and not using the generic term nurse, because it's just not the right term, even though our clients will use it. When you hear nurse, you have to ask some follow-up questions to make sure, because it influences how they're configured. If we were going to replicate something in TouchWorks that a quote nurse did, we have to know, okay, how are they set up? And it's because it's not exactly one way, you have to know, oh, what's their ordering authority? What's your system set out? Are they ordering in this person's name? Is this person, do they have this right? So when you hear that term, it's more that you understand the research you need to know and how their system is configured. And then last, we have front desk. Now, there's a lot more roles, and I have those in the glossary. The reason I picked these three is this is the mainstay of the office, right? Front desk checks people's in and out in general. Medical assistant is going to room them, take vitals, etc., maybe enter some historical things. The provider is going to care for them. And then somewhere in here, someone's going to drop some charges. And those could be handled by the front desk in some offices, or you may have a central billing office that does that. But these are the three main roles that we should all be the most familiar with. Next, inpatient world, so we still have the same provider, so that doesn't change. Another common term in the inpatient world is a service. What that means is it's usually a collection of people. It could be nurse practitioners, PAs, physicians, residents, which we're going to talk about, interns, because it could be people who are medically getting their training, and they're on a service like the cardiology service, the ID service. That means they're the group of people providing cardiology to inpatients. So big cardiology groups, or in academic medicine, so we're in big hospitals where we're trained to be doctors and nurses, etc., is they'll refer to it as the cardiology service, the infectious disease service. So you'll hear the word service, which again is a generic word that can mean a ton of things if you don't have the context that is clinical medicine. Then we have hospitalists. So one thing, right, back in the olden days, if you were a doctor and Rob Sloan was my patient, then Rob Sloan got admitted to the hospital, I would provide care to him in the hospital. So the same doctors did care in the hospital that did outside of the hospital. Starting in about, I actually know this because I was on the first hospital service the month it started. So it started about in 1996, 95, 96. They started saying that, hey, you know what? Doctors in the outpatient world are busy. They can't tend to tests that come back real time. And so the patient's staying in the hospital longer than we think they need to. So what if we had doctors who just gave care in the hospital so they could admit new patients, etc.? So we started having a brand new term called hospitalists, which are physicians or APP who care for hospitalized patients. You still have specialists. Like if you're a cardiologist, you could still, in some small towns or small cities, see your patient as an outpatient, as an inpatient. But in most large metropolitan areas, that's not going to happen. There'll be people in your group who do the hospital care. So like a cardiologist, a GI doctor, a kidney doctor, they'll have people in their group who see patients in the inpatient, and different doctors. They probably rotate through, so everybody does inpatient, everybody does outpatient. For more general medicine, not specialty type care, then you tend to have someone who is your hospitalist at the hospital. They're employed by the hospital, versus in the cardiology situation, they're employed by the cardiology group. And those people give care in the hospital. Now, we're going to talk about, we have lots of specialists who go from outpatient to inpatient on the same day. A great example of that could be surgery. That, again, varies by size, but sometimes we will hear the term hospitalist, or understanding that in a medical group, this cardiologist might be an outpatient doctor most of the year, but 1 month of a year serves as a hospitalist. You start to understand, oh, that's a unique situation. That means in TouchWorks, they are caring for people, they're going to have tasks and results, and then all of a sudden they're gone for a month. How do you handle that workflow? Or maybe people do it where once a month they do a week in the hospital. So 3 weeks in the outpatient, 1 week in the inpatient, and they're not crossing over. Well, that makes very special circumstances that might happen with coverage views, right? And how you might configure the system, and also how we might design it. And then lastly, we talked about registered nurses, and that's the most common kind of nurse in the hospital. Personas. Some of you have heard this term before. It's a UX, or user experience term. When we design the EHR, we like to think of people like we call them actors even. Think about movies, actors. These people represent the people who use our system, right? So traditionally, a lot of times, if you looked at EHR development, even us here at Allscripts and TouchWorks and Altera, we would say like, oh, we have a physician persona, a nurse persona. Well, that's not really, I mean, if you design your system like that, you're not going to be really accurate, because there's lots of different kinds of physicians. There's different specialties, there's different sizes of practice, people who do inpatient and outpatient, which we just talked about. And so one of the things that we have worked on a while back was having a much better persona target. And you'll notice here, this tells you a little bit about how persona is used, because the persona, meaning the person, understands the pain points, the motivations, the traits, how they use technology, everything about who they're representing. So a primary care doctor, a family medicine doctor, and a general surgeon, you can't use one persona to represent them both. So the next phase is, instead of just having a physician, then you would see things like, oh, well, this is our primary care persona, and this is our specialist, and this is our surgeon. You actually didn't see all three very often, which to me was a big problem. Again, you do not have to memorize any of this. I just want you to understand it, because it starts to get you the understanding of why some of these terms are important. So this is a big graph out of a spreadsheet that I have that we created when we were talking about, okay, who are our personas? And to make it fit, I cut off the word persona, which all just said physician. But you'll notice that all these physicians do slightly different things. They all have a get credentials, MD or DO, right? They could practice in acute, ambulatory, or doing procedures like surgeries or like procedural centers, like where you do like GI scopes, etc. So where they give this care differs, and then if they are teaching or academic makes a huge difference. So if you, the third box down, if you're a physician who does procedural based specialty, so that's like a general surgeon, right? That means you're going to give care in the hospital, in your office, and in a surgery suite. This person doesn't do academic, so they're not going to teach residents, fellows, interns. And you'll notice back in the comments there, it says if you're a surgeon like this, a procedural specialist who's not in academic medicine, you're going to have a lot of other people working for you. You see a lot new initials there, like a CST is a certified surgery tech. So you have other people who sometimes have to fill the roles that could have filled the role when you're in academic medicine. And all of this matters because it affects the workflow. Next thing we have here is just common terms. So intern, resident, fellow, attending. A physician who practices in the outpatient world, we rarely call them an attending. If they're not in an academic center, we don't put that extra word in front of it. But this is sort of the academic hierarchy. Basically, you finish medical school and then you enter a residency. And the first year of your residency, you're called an intern. It's an older term, but it just refers to the first year of residency. So some specialties, you do an internship in like a rotating specialty, which we call transitional, before you go do your dedicated residency, which could be like anesthesia does that. If you're in family medicine, your first year you're intern, your second year you're resident, but you're always a resident even though you're an intern. But so the intern is your first year, a resident is the next year. Once you finish your residency in whatever specialty in, then you can set to be board certified. A fellow is someone who does additional training after their residency. So after, in most states, once you've completed your intern year, you can be fully credentialed as an MD. So meaning you have all the privileges of an MD that your state allows. We refer to all of these people with the same credentials. So a medical student has credentials like MS for a medical student, and then it has a year as a 1, 2, 3, 4 to designate the year that you're in. But interns, residents, fellows, attendings, they're all MDs or DOs. But this other term is just refers to where they are in their training, which could influence how much supervision they may get. The reason we care, again, is if someone says, well, this person's a fellow, it's important to understand, okay, that means they're a fully functional MD who's done more than one residency and is getting more training, so they're probably allowed all the rights in the system of any doctor. Whereas an intern, you might think of that, if you're dealing with results verification, you may think, oh, that person's an intern. That means they are an MD. I need to know, or what are they able to do or not do the way this client has configured the system? Because if you look across our clients who have residencies, because we have a lot of those, there are people who the results come back to the resident. There's people where the results come back to attending, even in the same institution. So the reason when you see these terms, if somebody mentions them or you hear them, it's just to help you ask another question. Which brings us to our next slide. Maybe, there we go. Why does vocabulary matter? So this is the interactive portion. So I don't care who goes first, but I'd like somebody to come off mute and tell me, why did we give you a glossary? Why did I just tell you these terms? Why does vocabulary matter? And I can't see the thing, so if somebody raises their hand, Scott, can you just call on somebody? Bueller?
Don't be shy.
I'll just pick your names. I'll go off and pick you and make you do it.
Piyush and Yusana came off mute.
Yeah,
Oh,
yeah.
I didn't see it. Sorry, guys.
That's good.
So
Just speak up.
Yeah, vocabulary matters because it will help us for the day-to-day work that we are doing.
Yep. And that's a great answer. Any specific how it will help you? Any ideas on that?
It will help
Well,
us understand understand what what workflow or what the user is exactly trying to do or tell us. So if we are using the same language, as in if we are using the same terminology, both of us, it's better for us, the user, as well as in case if I hand over the case to someone else or pass it on to a different queue for them as well in order to analyze what's going on or what has been done.
Oh, I love that answer, right? Because remember, we got to have a lot of people work on these same cases. So, as we pass it back and forth, the more we have a shared understanding, right? The more important that is. I did not say that very well, but you got the point. Who else? Somebody else had a reason why does vocabulary matter?
well, like for me, I used to, it took me time. I'm like, what's outpatient versus inpatient? And, years ago, especially starting with this job, just knowing terms like that and understanding what the client's saying per the case and what they're exactly needing help with makes a huge difference. So we don't seem incompetent. That's for sure.
Yeah, so all great answers. I'm gonna move on here. So thank you for participating. So here are some of the ones that I threw on there, and this list is not complete, right? So if you're gonna combine your knowledge and experience over time, and if you understand these terms, like how clinics run, their common workflows, it helps you with your critical thinking, right? Because you're got to fill in the gap. So if I told you that I walked on water today, most of you hopefully will not believe that. Or some of you will say, oh, you walked on water. So there was a puddle on the ground. There was this, like, were you on a lake? You're going to ask, it helps your critical thinking because you have a mental model of how it works. So if I say I walked on water, you're not going to be like, wow, Jean's pretty cool. She walked on water, right? It's like, no, because there's a lot of ambiguity in that statement, right? So it helps you fill in gaps, but you have to be cautious, right? So you have this knowledge and experience. It really helps you ask better questions. And I think that is a really key part because one of the things we do as new learners, we learn something. And so we have a knowledge base. So when somebody says something, and I see this in our cases all the time, and this is our clients do it to us all the time. Development does it all the time. Services does it all the time. Support does it all the time. Meaning we're all in the same boat, right? Nobody is doing any better at this than the next group because it's something that's against human nature. Have you guys ever done one of those things like on social media? They'll show like a paragraph and like the words are like sometimes the words are backwards or it's missing characters and they say like only X% of the people can read this, but you look at it and you can all read it because your brain knows what that's supposed to say. It fills in those gaps really easily. That happens to us all the time. If somebody says, oh, a physician did such and such in the system, I don't question, did that physician have the rights to do that? I assume, well, hey, they're a physician. But because of my experience, I say, oh, you said physician. This is somebody who is credentialed as a user provider and they have an ordering authority of what in your system? Like it makes me jump through to a different set of questions. I don't have to start at the beginning and say, are they a user? I can pretty much assume they're a user provider, but I'm going to ask that question because the person didn't tell me it. It lets me confirm my answers because what we have to be really careful of is not filling in and assuming we know the answer. Because if you've seen one person's configuration at TouchWorks, you've seen one person's configuration at TouchWorks. It's highly configurable. So having that vocabulary is really important so that we can do it. It also, somebody mentioned this, increased trust and presents you as the expert you are. You have an expertise, and this lets you speak in a language and use terms and ask questions. It helps us make sure we really understand the answer or the issue that's going on. So if someone says a nurse did such and such, the first thing I'm going to ask is, hey, you're using the term nurse. So, and you were mentioning med reconciliation. Is this person credentialed as an MA, RN? Like, are they allowed in your state to do it? You're talking about hitting the yellow button. It's not that I care if they're allowed in their state, but it's giving me enough information to be like, I want to make sure I'm picturing in my mind what they're doing because I have to see the system in my mind and understand what you're describing to me, right? This helps me understand the issue. It also helps us in terms of concise and complete written and verbal communication, right? So we could say provider, we can't assume everybody knows what that means. Provider, I just taught you, could be a lot of things. A lot of times people will feel referred to as social workers as providers, because in TouchWorks, almost any ancillary medical person who gives care who might bill on their own, a psychologist, a speech therapist, a dietitian, a social worker, they're all going to be configured in TouchWorks as user providers. But provider in that case doesn't always mean the same thing. Okay, next we're going to talk about, and again, these slides, the workflow in a clinic varies on a lot of factors. One of the most common variables in, actually, I'm going to ask this a question. So here's pop quiz. What has the biggest influence on who does what in an outpatient clinic? There's one variable that affects who does what in an outpatient clinic more than any other variable. Anybody having a guess? Why don't you just type it in chat so everybody can just throw a guess in there. And then Rob, I'm going to ask you to read them to me. So just if you have what variable determines the most about who does what in an outpatient office? Any guesses? Don't be
I
shy.
have no responses yet.
Throw something in chat. What variable? I'll make it a multiple choice. The kind of medical specialty, the state they practice in, the size of the practice, whether it's MD or DO. Which one of those do you guys think it is? Throw it in the chat so Rob can read them. And there's no penalty in guessing, right? We're all learning here. Like, don't be afraid.
What type of practice?
Is that our one answer, or is that the majority answer?
That's one answer. Here comes another one.
Okay, come on.
That was with a question mark too.
What type of practice? Sorry.
Yeah, very good, Rob. Very good.
Thank you.
What else we got?
The specialty.
I will tell you that almost everybody gets this question wrong. Who does this work?
The physician? Another question mark.
Yeah. So those are all great answers. The answer is size. Size matters. Because if you're in a small office, a really tiny office may only have 2 people in the office. A front desk person who also does all the billing and rooms the patients and takes all the phone calls, and the doctor who sees them. So that workflow is who does what in the office is going to be influenced by the size. When you get to most average size offices, most providers are physicians, right? So the physicians, AP, they have someone assigned to them, usually an MA, who's going to room their patients. That person and maybe the front desk takes phone calls and triages, does refills, arranges referrals. As you start to get to more medium plus and larger offices, then there's a dedicated referral coordinator who does it across who does it for all the doctors in the office. If you have 50 people who work in your office, you're going to have a referral coordinator, somebody who does refills. If you're in a pediatrics office and you're of size, right, you have more than 2 or 3 providers, you might have someone, their whole role is to give the shots for the day, the immunizations, because you give so many that if you're doing that, you can't room the patients. So who does what in the office is affected more by size than even specialty. There you go. So when we look at how do we work, so you probably have seen like Visio diagrams on workflow before. I like to put it in a simple outline. I actually like this format. So this was done by some of our UX designers when we were looking through common workflows for a project we were doing. And I really liked this visualization, so I threw it in here. Again, you're going to get the slide deck. The job is not like, I'm not going to say, what's the third, the test, it won't say, what's the third step in the third column? That is not the point. The point is to start to understand a general basic workflow across all kinds of outpatient clinics. Because if you understand that, if you take nothing away from all the training we did, there's 3 things that I think are the most important. Understanding workflow and having a basic workflow that you can put the client's workflow up against so that you can ask good questions. It's going to be about writing clear and concise documentation of the case, since we're communicating asynchronously, and it's using the correct terms when possible about TouchWorks. Those are our 3 goals for this training program. So here's a workflow. You'll notice this is check-in. So this is the patient who has arrived at the medical office. Okay, what happens? Well, usually in a PM or practice management system, because remember, TouchWorks is an EHR, it's a clinical documentation only system, so it doesn't function without a PM or practice management system. The practice management system is where you document the actual appointments. It's the source of truth for the patient demographics. It's where you schedule appointments. It's where you do billing. So we don't really run without a PM system. So when the patient arrives in the office, one of the first things they do is they click a button in a PM system that says the patient has hit the office, because that time is important for time studies. Clinics track that also, so we don't lose patients. We've all lost a patient or 2 in the waiting room, meaning that people forgot they checked in because nobody clicked the button. And then somebody says, that guy's been sitting in the corner for like ever. Who is he? And then we say, oh my God, we're so sorry. Right? So you mark the time in. You'll notice the top. You're validating insurance. You're determining what's needed from the patient. You're giving out paperwork. You're getting the forms back if you have them. You're entering information into the PM system or the EHR. Sometimes you're collecting copay. You're alerting the back office. So you're saying, hey, this person's now ready for you to bring them back. Because when they first get in the clinic, the front desk has to do all these things. So they are not ready for the nurse/MA is the real term, the back office, to bring them back. Then they set reminders, like if a patient's waiting. If we've missed a patient, they have to air recovery. People walk in without appointments and they have to decide what to do with them. So this is all the things in general that happen. Underneath each of those verticals, you see, okay, what does that mean? Well, so validate insurance. They probably take their ID, they get their insurance card. They might have to run their insurance card through a validation tool. So like Medicaid has a thing where we do eligibility checking to make sure they're still eligible for their insurance. If they owe us money, we might evaluate their account. So then we have to have a consent to treat. We have to validate their demographics, so their phone number, their address, because they might not have been to the doctor for a whole year. So those things could change. We have all sorts of questions that we have to ask them because the EHR wants to know and the government wants to know. Well, how do you want us to communicate with you? Do you want to get stuff in a portal, or do you want us to email you? Do you want us to text you? Do you want us to call you? Your ethnicity. Where would you like to have your medicines filled today? Where would you like to have your lab filled today? In one clinic, this could happen during check-in. In another clinic, your preferred lab and pharmacy might happen during rooming. So again, these can vary, but this is just an overview of how this works. And again, we're not going to go through each one of these in painstaking detail because you're going to have the whole slide deck. So this is rooming. So we're trying to get the patient in the room ready to see the physician or APP. So first of all, they have to know what room is available. Certain patients have certain allergies like latex that can only go in one room, or they have a certain kind of condition where they can only go in a certain room. So one of the jobs the nurse has to do is they have to know what rooms are available. They have to know who's in what room. They have to know the patient is ready. So like in TouchWorks, the front desk, when they're done with all of their work, they make the person arrived in their PM system in a fashion that it comes to TouchWorks. In the schedule, you see a big green ARR, arrived. Okay, now that patient's ready for rooming. They have to do any pre-visit planning. They could have done that before the visit as like a huddle, which we'll talk about. RFV stands for reason for visit. Why are they here? You got to know why they're here before you go get them. Like, what are they scheduled for? Because again, that can influence the room. It can influence the vital signs you have to gather. Then you're physically, notice how many steps in here before you actually go to the waiting room and get the patient. Then you're going to do the vital signs. You're going to review their history. You're going to do interval updates. And this could depend on the kind of practice, all sorts of stuff. But you're going to do things like, go through their medical problems. You're going to do medication reconciliation. Are you taking this medicine? You're not taking it. Are you allergic? Social history. These are the most common ones that people do. You could flag things that are important for the provider. Next slide. This is the provider actually seeing the patient. Notice those blue boxes, there's stuff before you go see the patient. There's stuff while you're in the room with the patient. And then there's lots of stuff you're doing after the patient to do your documentation and also handle things that come back after the visit. So then we get to finalizing post-visit and things that come back. So the doctor's workflow, doesn't end when the patient leaves the room. And then lastly, we have the checkout process. We print stuff for them to take home. We tell them we sent their stuff to the pharmacy. We capture charges. We schedule follow-ups. So those are basic workflows and all the steps that is the minimum you should be familiar with when you're supporting people in an ambulatory or outpatient setting. Okay. Who knows what this is? Oh, and everybody might
A grilled cheese?
grilled cheese sandwich. Thank you very much. Now, this is the point where everybody comes off mute because you're going to do a lot of talking for the next 15 minutes and also if you have questions. So this is your homework, but we're going to do an exercise prior to the homework. Does anybody on the phone, and Rob, Scott, you are equally, please participate. Anybody on the phone know how to change the oil in a car?
Yes.
Rob, would you like to volunteer? So could you please tell us the workflow to change the oil in your car?
Yes.
Go for it, Rob.
Which
he went
Rob?
on mute. We got two Robs. Which one?
Whoever knows how to change the oil in their car,
Okay.
tell me.
I will take a stab, but
Okay,
I
perfect.
foresee myself being inadequate with this, but I'll do it anyway.
Well, this is why it's an exercise, and I really appreciate you doing it because you may not make it right.
Sure.
Go
Sure.
for it.
Okay. So changing the oil in a car. You're still going to make your point, but I'll make it brief. Make sure the car is turned off. Make sure the tires will not roll back. Have your car in a place where you can get under it or jack it up. So in order to jack it up, you need to get a jack. You'd need to position it under the car. You'd then need to operate the jack by putting the handle inside the jack and cranking it so that the car is up high enough that you might be able to get under. You would then identify and locate the oil drain, the bolt that is the drain for your oil. You would need to get a wrench that is the right size to fit that bolt. You would need to loosen that bolt to drain the oil. You would need to, pop the hood. There's so many steps, Gene. I think you can make your point based on that.
Yeah, so I picked change your oil because a lot of people do not know how to change your oil. I also picked change your oil because my husband is a car guy. And so when I was coming with my example of grilled cheese, which we're going to talk about, and peeling an orange, I said, oh, you know what? So I called my husband this morning. I'm like, and by the way, this was taking one for the team. You don't understand how precise my husband is and how much he wants me to know how to change my own oil to begin with. So the fact that I said, hey, just run through the steps of how you change your oil again, right? That was a 30-minute dissertation. I just want to tell you all right now that I took that for you as a team, right? So Rob is right? It's so easy when we're doing steps to reproduce or workflow. We all just gloss over steps, right? So at first he was like, oh yeah, well, you jack it up. Oh, well, he didn't describe how you jack it up. Oh, okay, yeah, we got to make sure you can get under it. There's no right or wrong, right? It's about being able to use the right terms. So the bolt that he was talking about, that's the oil pan plug, right? So if we all knew what oil pan plug meant, right? Something like that. Otherwise, we're describing it, which he did beautifully as a bolt. So you can imagine all of those steps. My husband's version of this was roughly, first you have to know before you change the oil, what does the manufacturer recommend? How often do you need to change it? There's factors that influence when you need to change your oil. If you are a truck that pulls a trailer and you go through a lot of hilly stuff, you need to change your oil more often. And he also left me with this as I was leaving. He said, oh, and if you have no money to maintain your car, you spend all your money maintaining the oil. The oil will influence the life of the engine, and it's the greatest number one thing you do for maintenance of your car. There you go. And so he went into a lot of great detail about how to change the oil. One of the things that he said was, hey, start the engine, let it run for 5 minutes first. Because if the oil is warm, when you stop and do all the things to get under it, put the oil pan under all good stuff, it'll run out faster. Then you got to make sure it all gets out. He spent a lot of detail on that when you put the new oil on, you change, when you're putting new oil in, you have to change the oil filter. When you change the oil filter, there's a little rubber gasket thing that's on the oil filter. But when you take the old oil filter off, that old one, that old little ring might stick. You have to make sure you have it off, because you put the new oil filter on and you didn't take the old ring off, it will leak all over the car. He also told a funny joke about, do you know how women change the oil? And if you've ever seen this video, the woman has the hood up. I take offense at this, but I'm not saying I wouldn't do this. And they sprinkle the oil all over the engine, sort of like how you grease a pan. Okay, I know how to cook. What can I say? So there's a lot of steps in doing it. And so a lot of times when we look at cases, there'll be like so much detail. Like the first 20 steps will be like, they logged in. Okay, let's just pretend whether we get that step, right? So what steps can we cut out and be concise about our language? What steps can we roll together, right? For example, if you're talking about doing your oil, you don't have to say, I went and got the oil and then I did this. You could maybe put 3 of those steps in one line. We assembled the necessary stuff, 4 quarts of oil, this, right? So how to be concise. But you start by being very detail oriented, just like Rob was. Every act you do, you have to think of in terms of the workflow. If we do that in the EHR, our cases would be so much better. If we can get our clients to do that, if we understood that, it's really important to just, and I'm going to hammer this every time we're together for the next 3 days, is how important workflow is. So that's your homework. Your homework, and you have a few choices. You can pick any of these YouTube videos on how to peel oranges, how to change your oil, or how to grill cheese. Or if you know how to do one of these, you can just sit down in your brain and think of all the steps. I want you to write it out longhand. You can write it out like we did in this Excel spreadsheet. And you can say so in this case, you could break it down with the blue boxes. But mainly it's the yellow boxes. That's each step. And if there's something in that step you want to describe, but we need to know that we know how to gather workflow. So Rob and I talked a lot about this when we were preparing for this course, because Rob, like myself, did implementations. So if you've ever been on implementations, you've installed the software at a clinic who's going live for the first time. One of the things you do is you do workflow gathering. You go out to the office and you say, okay, tell me how your office runs. And so a lot of times they're very open-ended questions like that. And people will leave out so many details. If we believed what they told us, that we would configure the EHR completely not the way we should, right? So I developed a system when I was doing this, and I felt like it was unfair because I knew how outpatient clinics ran because I still was being a doctor and I worked in one, right? And I knew enough about medical specialties that we actually just inferred the things we thought would be common, and then we asked questions where it wasn't. And because we use the correct clinical terminology, we could say, tell us how you do triage at your system. Do you have a dedicated triage nurse who does triage every day? Do you rotate people through? Hey, how do you room patients? Does each provider one-to-one with an MA? So because I had that knowledge, we could gather that workflow in a lot less time. You are going to have that same expertise, but the first skill is making sure that you think of every step. There's 2 ways to gather workflow. The first way to gather workflow is you just ask somebody, right? So you can take anybody else in your family, you can pair up with each other, and you just say, hey, how do you make a grilled cheese? And you document what they tell you, and based on your expertise of grilled cheese, you ask them questions to try to elicit steps that they didn't provide you. Does that make sense? Anybody have any question about doing it that way? That is the
Let-
most that is the most common
Gene,
way.
let's
to
do
get it
that.
done. Yep.
Let's do that as an example, as an experiment.
Yes. So, Rob, would you like to be the workflow gatherer or the workflow E?
I want to question you.
Okay, great.
Okay, so Gene, how would you make a grilled cheese?
The way I make a grilled cheese is I make sure I hand shred the cheese. It's really the key to grilled cheese for me. So the kind of bread matters less to me. So I use whatever bread I have at home. And so that could be any kind of sliced bread, white, wheat, sourdough. It does not matter to me. I tend to use what I have at home. And then I basically get cheese. I like a blend of cheddar cheese and something like Gouda. And so I would take both those cheeses and I would shred it.
Okay, so when you would get the cheese, would it be a block of cheese or is that pre-sliced cheese that you then break apart? What do you mean by shred?
Oh, yeah. So, no, I buy a block of cheese and I use a hand grater to grate the cheese so that I have like shredded cheese like you would get in a bag, except I've done it by hand by taking a block of cheese.
Ah, okay. Thank you.
So I would shred the cheese, and then one of the keys is that you have to have some kind of fat on your bread. So I tend to use butter if I have it that's soft. If I only have hard butter, I will use mayonnaise because it works equally well. And so I'm going to take 2 slices of bread, and on one side of each slice of bread, I'm going to put butter or mayonnaise. And then I'm going to put them, so I'm going to get a skillet, like a 10-inch, 12-inch skillet. I think a 12-inch skillet. That's what I have. I'm going to put it on my burner on medium heat. So on my
Do you-
burner, go ahead, yeah.
Sorry to interrupt. I was going to ask, does your burner cook with electric or gas?
Oh, great question. I have an electric flat top. So I'm going to take my pan, I'm going to put it on the flat top burner.
Okay,
I'm
next
going
question.
to-
Is your pan non-stick, cast iron? What type of pan is it?
Yeah, great question. Non-stick,
Okay.
like Teflon coated.
So does that mean you do have to put oil or something in the pan, even though you've buttered and mayonnaised your bread, or no?
No, I do not put any other oil. Great question. I don't put any oil or spray or anything. So I take my 2 slices of bread, I take the surface that has the mayonnaise and butter on it, and I put both pieces of bread with that surface down on the skillet at the same time.
Mm.
So they're laying beside each other. Then I sprinkle the shredded cheese on both the other side that's side up, right? The blank side up. I put the shredded cheese on that on medium and I cover it with a lid.
Mm.
So I had to have a lid to my pan. I also need a pancake turner, spatula, whatever you want to call those things. Something that I can turn it over with. I like something that's flat.
Since it's non-stick, would you make sure that it's also like a silicone spatula?
You know what? Yes, that's a great point. You should do that, and I do that. I have been guilty of using a metal spatula, which scrapes the surface off, and I try not to do that. I have mostly silicone or like, I don't know, plastic turners. Yep, great question. So I have it down.
I
put
think that probably proves the point. I could keep going though, because I love grilled cheese.
I put the lid on until the cheese starts to get melty and the bread is browning, and then eventually I'll skip the point. You flip them over, etc. That is how I make grilled cheese. I read an article one time that shredded cheese was the best way to do it, and that's how I do it. There you go. But you get the point, right? Rob was perfect. He asked me all the questions because I skipped lots of details, and those details may matter. Because if you were doing that in a cast iron skillet, you would be doing that a different way. Your heat would be different. If you put a lid on it, might be different. Plus, the way you make a grilled cheese in your family, you may use sliced cheese. You may be convinced sourdough is the right bread. Whatever those answers are, because there are no wrong answers. Because workflow gathering, there's no right or wrong. You're just trying to gather what the person is doing. So you can interview someone like this and ask them questions, just like this. You could pair up with each other. You could just sit down for your own memory and watch it and then read it to somebody and say, hey, what do you think about this? You can send it to me if you want me to look at it. You can watch these videos. I picked videos for a reason. And these are different videos because a lot of times we talk about using videos and getting client workflow. And sometimes you'll see how hard and how much longer it takes to get it from a video than it is to capture, to know exactly what they're doing. Matter of fact, I didn't tell you how much cheese to put on it, right? If you put 2 pounds of cheese on it, it's going to overflow your pan. It wouldn't work. So you start to get to that precision. So your homework is gather a workflow of either peeling an orange, changing your oil, or grilling cheese. Talk about it amongst yourselves and be prepared to discuss it tomorrow when we talk about this exercise. And with that, we are done today. I am open to questions. If anybody has any questions, glad to talk about anything we went over that needs more explanation. I will send this deck out as soon as I'm done here, as well as the other glossary that I made about common outpatient terms. Any questions?
Questions so far?
No questions. I'm just amazed at how fancy your grilled cheese is. Mine's just bread and American and butter.
Yeah, you know what? One day for Christmas every year we did something different. It was usually some version. So my uncle loves grilled cheese, so I did a lot of research on how to make the best grilled cheese, and then I attempted